All right. Well, thank you for joining me today for this presentation. Today, we're going to talk about medication deprescribing. And there are a number of things that we will cover today. So I'm excited to kind of jump in and get started. My name is Rebecca Brynjolfsson. I am a faculty member at NDSU in the School of Pharmacy. And I'm just going to close out of this one. And I work with the GWEP here in the Dakotas. So I have no relevant financial interest or other relationship with the manufacturers of any commercial products or providers of commercial services that are discussed in this activity to disclose. So kind of the standard disclosure statement. And at the end of this presentation, participants should be able to define medication deprescribing, identify factors that should be considered in medication deprescribing, identify resources available to guide decisions related to deprescribing, and to practice deprescribing in older adult patient case scenarios. So I think the last time that we talked about deprescribing in this setting was a couple of years ago. So there have been a few different resources that I wanted to share with you since that time, and also some updates that have come out since then that I think will be of interest to you as well. So I'm going to go over to start with kind of some characteristics of medication use in older people and thinking about just some examples of why we should be deprescribing or why we should be thinking about that in our practice. So as patients get older, their specific response to medications becomes more complex. And the reason it becomes more complex is because medication response is based on pharmacokinetics, which would be things like absorption, distribution, metabolism, excretion, and pharmacodynamics can be altered due to physiologic changes. So we know that there are just changes that happen as we get older. So for example, we have acid changes in the stomach that happen. Patients metabolize medications differently. We know that GI absorption changes as adults get older as well. So those are some examples of responses that can be altered due to physiologic changes. So then it makes sense that medications that patients use when they're younger may not be the best choice or may not be used in the same way at the same dosages when they're older.
Rebecca, this is Nicole. Sorry to interject. I've had a couple people in the chat say that you're coming across very quietly. And so I don't know if there's a volume adjustment that you can make to maybe make it a little bit louder.
Better for those of you who are commenting?
No.
It still seems a little bit quiet.
How about if I hold the microphone very closely to me? Is that better?
That does seem better.
Okay, I will hold the snowball mic then.
Thank you.
We'll go from there. All right, so older people are also at greater risk for adverse drug reactions. So an adverse drug reaction has been defined by Edwards and Aronson as an appreciably harmful or unpleasant reaction resulting from an intervention related to the use of a medicinal product, which predicts hazard from future administration and warrants prevention or specific treatment or alteration of the dosage regimen or withdrawal of the product. So that is a long definition, but it certainly captures the things that are involved in adverse drug reactions. And so older people are also at risk of experiencing inappropriate prescribing, polypharmacy, missing appropriate therapy, and medication non-adherence. So these are all characteristics that we want to keep in mind as we're thinking about medication use. So what is deprescribing then? Deprescribing is defined in Deprescribing in older adults with cardiovascular disease as a comprehensive definition, including an organized process of medication removal or dose reduction, oversight of the deprescribing process by an appropriate member of the healthcare team, with a goal of improving one or more specific outcomes, and consideration of an individual's overall physiologic status, stage of life, and goals of care. So I think it's really important to think about the 4Ms and the 5Ms when we think about deprescribing. So not only is it that we should be thinking about whether, or medications in general, that's one of the 4 or 5Ms, depending on how you're looking at it. But we also think about multi-complexity, and we think about what matters most to the patient. And so these are things that all can influence our choices and our recommendations in deprescribing. So in which situations should we really be considering deprescribing? So certainly if patients are having adverse drug reactions, that is a reason to consider deprescribing. Sometimes we may not recognize that a patient is having an adverse drug reaction, and another medication may be added on to that patient's regimen or routine that would result in a prescribing cascade. So for example, if a patient is prescribed a medication that causes dry eyes or dry mouth, and then the patient comes in to see a provider in the clinic and is reporting that they're having dry eyes, if it's not recognized that that could be a potential adverse drug reaction of a medication, then it's possible that a patient could be recommended to use things like artificial tears to treat the dry eyes, when really the dry eyes are a result of an adverse drug reaction, and perhaps there should be a change made to the medication if possible. So that's another situation when we should think about deprescribing or making alternative recommendations. Polypharmacy is another area where we can think about deprescribing. We have a lot of clinical practice guidelines that make a lot of different recommendations for a lot of chronic disease states that many of our older adult patients will be experiencing, and trying to reconcile all those guidelines and to make sure patients are on appropriate therapy can certainly lead to large numbers of medications for patients. And so really thinking about what the patient's goals are and what they're hoping for can help you to kind of filter through priorities for treating patients and making sure that they're able to take the medications that they need to take. Polypharmacy has been traditionally defined in the past as 5 or more medications, but when you think about many guidelines for common disease states, chronic conditions, it's quite easy to get to 5 medications or more. And so as we'll talk about a little bit with the deprescribing, with some of the deprescribing articles later on in our talk today, there is maybe some thought about whether that number should be increased to be considered polypharmacy, that really you might find more patients who are taking even higher numbers of medications that would be more ideal candidates to target first for polypharmacy. Although it's always recommended certainly to evaluate patients' medications to make sure that they're only taking the medications that they need to take and that are appropriate for them. And then at end of life and in palliative care, there are definitely some guidelines and some more recommendations for when to consider discontinuing medication. So when we talk about patients who have a limited life expectancy or life expectancy less than 6 months, there are definitely some chronic medications that there's evidence to show that you can safely discontinue them because you're not going to necessarily expect to see a benefit from continuing those medications to decrease pill burden. And then obviously, the last one, if there has been a change in risk versus benefit since the medication was originally prescribed. I think one of the articles we'll talk about has tried to really help people start to think about the idea that just because a patient is started on a medication doesn't mean that they'll continue it indefinitely, that it should be an expectation that patients may stop medications that they are started on, not only from our perspective, but also from the patient's perspective, because sometimes patients can be resistant to stopping medications they've been on for a long time. But as patients get older and their physiology changes, that risk benefit also changes. And so it's important to be able to have those conversations and to think about whether a medication is still appropriate based upon the benefit that you would hope to see from it. So there definitely are some instruments that are available to guide deprescribing decisions. And so here I have some example of
Occupational
implicit
therapist?
instruments. And these
Okay.
are instruments.
Okie dokie. Okay,
I
I'll
think
see you.
someone is
I'll see
unmuted.
you.
If you can, I hear some background noise from a few people. If you can make sure that you're muted, please.
So there are some example implicit instruments, and these are instruments that do require you to still obviously use some sort of clinical judgment in screening or in reviewing medication. So it's not an explicit instrument, which we'll talk about, which is much more descriptive in how to respond to potentially inappropriate medications. But there are a number of different instruments that have been studied in the literature that are available, and they have a lot of different strengths and weaknesses, but there's not one perfect instrument that seems to work the best for everyone. So there's lots of good instruments to start thinking about. Some of the more common things that we talk about, though, are more explicit instruments, which give a little more guidance on exactly how to approach deprescribing. And one of the instruments or criteria that we commonly talk about is the AGS Beers criteria. And just as some breaking news, the 2023 update is available, and I'm actually going to go ahead and drop the link to that in the chat so that you can check that out yourself. And it is free access, so you should be able to access that if you are following that link. So the AGS Beers criteria is updated approximately every 3 years or so. And so it was last updated in 2019, and in May, we had the most current update. So that's something that we'll be talking about in a future Echo. Probably in our September one, we'll go through what some of the changes have been to that AGS Beers criteria. So plug for coming back in September to learn a little bit more about that. And then also STOP, which is kind of paired with a START criteria. These are a little bit older. They haven't really been updated. So there's some good information in there, but they are more outdated than the AGS Beers criteria. So STOP is a screening tool of older persons potentially inappropriate prescriptions, and STOP Frail is used in frail adults with limited life expectancy. So those are two other instruments that you might look at. So in order to talk a little bit about perceptions of deprescribing, there is an article that was published in 2021 that looked at primary care clinician and community pharmacist perceptions of deprescribing. And they looked at primary care providers and community pharmacists in Kentucky that were surveyed. And the survey asked questions related to deprescribing experiences, beliefs, attitudes, influencing factors, barriers, and facilitators. So they asked a lot of really great questions, and they had some results that came back, and they identified as clinician barriers: insufficient time available to spend with patients and communicate deprescribing recommendations was 58.6%. Patient attitudes toward the medications they take, 69%. So again, that's really a high number. Difficulty in communicating directly with other healthcare providers, so subspecialists, about deprescribing recommendations, also fairly high. When you look at pharmacist barriers, they also indicated that difficulty to communicate directly with other healthcare providers about deprescribing recommendations, as well as insufficient time available to spend with patients and communicate deprescribing recommendations. And then finally, a lack of trust between healthcare providers and pharmacists. Those were the three highest in that category. But both pharmacists and clinicians agreed that lack of education and training related to deprescribing activities, as well as lack of information in electronic health records, are also barriers to deprescribing. So there have been some more recent studies that have been done that help to address some of these, I think, and are worth us paying attention to. As far as facilitators, things that would help patients become, or things that would help us to be able to deprescribe better for patients would be adequate time to spend with patients to discuss deprescribing recommendations, trust between healthcare providers and patients, patient attitude toward the medications they take. And then from pharmacist facilitators, ability to communicate directly with healthcare providers, adequate time to spend with patients to discuss deprescribing recommendations, and trust between healthcare providers and pharmacists. Both clinicians and pharmacists agree that training and experience with deprescribing, as well as clinical guideline updates that support deprescribing recommendations, are facilitators. And so today, hopefully, I'll be able to share with you some information about deprescribing and some guidelines or some information that can help to support you in deprescribing here in this presentation. So when we talk about overcoming barriers to deprescribing, there is a group that is out of Canada that is the Canadian Deprescribing Network that has a lot of really great resources, and talks about actually 5 barriers to deprescribing. And so there are myths that are associated with deprescribing, and that's what this video covers. And so all of those myths, I'm going to try and see if I can quick catch some of them for you here. So there are things like adequate time, or if you deprescribe, your patient's symptoms may return. That was the second myth. So the third myth is there is no evidence that deprescribing will the deprescribing can be done safely, and that's something that the video talks about. And the fourth myth that the video talked about was patients are reluctant to stop their meds. And this group has actually found evidence that up to 70% of older adults are willing to stop their medications if patients are given the option and talked to about reasoning why those medications may need to be discontinued. And the fifth myth is I don't have time for deprescribing. And some of the information I talk about here in the rest of our presentation, we'll talk about some potential ideas for how you might find time for deprescribing or make some changes to your workflow that could help with deprescribing. Okay, so that was a quick summary of the video. They do a much better job of going through it than I do. It's a really good video to watch in this Canadian Deprescribing Network. We're going to talk about some of the resources that they have available for deprescribing today in this presentation. So this group at deprescribing.com is the Breer Research Institute and the University of Montreal, and they have guidelines and algorithms that are available for several different disease states. And so the algorithms they have are for proton pump inhibitors, antihyperglycemics, antipsychotics, benzodiazepine receptor antagonists, and Z-hypnotics, and cholinesterase inhibitors, and memantine. And so these we'll go through again as we talk. They're some really good algorithms. They are mainly published from 2018. So again, just keeping in mind that some things may have changed since 2018, they're still a really great reference or starting point. Another resource that you might use is a U.S. resource that is the National Institute on Aging, and this is the U.S. Deprescribing Research Network. And I have included the link here for you as well, and you can see the website that you'll come to if you follow that link. They have data and resources, but they also have resources for clinicians. And this is a great place to find some information on deprescribing as well. So I did pull up the page that comes from those clinician resources, and you can see that they have a general approach and stepwise approach to deprescribing, and they actually link to some of the Canadian deprescribing resources that I shared with you as well. And they also have guidelines on potentially inappropriate medications. They have the American Geriatric Society Beers criteria. I'm not sure if this one has been updated to the new criteria yet that I included in the link for you, but that is there. And then they also have the start-stop criteria, which we talked a little bit about as being an explicit instrument that you may use to help guide you in your recommendations. And then they talk about a framework for decision-making for older adults with multiple chronic conditions that is from the American Geriatric Society. And I think this is really helpful if you haven't had a chance to read this before, to look at this to see how you might best approach caring for older adults who do have multiple chronic conditions that have a lot of guideline recommendations that we would hope that they might be on, and how you would approach that as patients get older. There's also more recently, in the last year, been an optimized trial that's been published. And this is a pragmatic trial, which if you remember from our discussion last time in April, pragmatic trials are trials that happen in practice. So it's trying to see what works in practice in a practice setting so that it's more generalizable to practice versus being really strict inclusion-exclusion criteria to where you would never envision you could maybe match up a patient in practice with the exact trial results that have come out. So the first article was published in JAMA Internal Medicine, and this was in 2022, and it talked about deprescribing education versus usual care for patients with cognitive impairment and primary care clinicians. And their inclusion criteria were adults that were over 65 years of age with dementia or mild cognitive impairment. So that's the population that they were looking at. And they looked at patients who had polypharmacy, and this was defined as 5 or more medications with at least another chronic condition in addition to their dementia or mild cognitive impairment. And they actually, their intervention was purely educational. So they wanted to see if educating patients by sending them a brochure ahead of time and sending them information, and certainly the patient's families were also involved to some extent in this, but sending them information ahead of time of a clinic visit, or sending them a survey, and then also providing education at a monthly session to providers would improve whether patients were prescribed potentially inappropriate medications. And they didn't see a lot of clinical difference, but they did have some interesting things that they found or that they learned, and some thoughts that I think are worth considering. And so even though there wasn't a lot of difference, they did talk about that potentially they needed to do this intervention with patients who were on more than 5 medications, that they might have seen more significant results in that respect. But the next study is intervention design in cognitively impaired populations, lessons learned from the optimized deprescribing pragmatic trial. And one of the things that they talked about in this trial was they went through, or in this article, they showed some of the training that they gave the providers and some of the information they sent to the patients. And the information was just like planting a seed, if you will, in someone's mind to think about something. Like maybe you don't need all the medications that you're on. Or when you're a provider and you're prescribing a medication, setting the stage as you're prescribing that medication for a younger adult, that they may not need this medication or the same medication for their entire life, that they may need to go off of that medication at some point. So that when you have that conversation, or another provider has that conversation with the patient later on, that they're more open to that idea of deprescribing, because when they started the medication, they knew they may not need to stay on it for their whole lifetime, or they may not need to be on the same dose or the same exact kind of medication their whole lifetime. So I think that that is a really good thing to think about and really wise, and something that they learned from. They also found that it was really helpful to have other members of the healthcare team involved. And so having pharmacists involved in reviewing those medications ahead of time, in the second trial, providers talked about how important it was to be able to ask your pharmacist, or ask a pharmacist to look at those medications ahead of time, and maybe to do that before your visit even happens. So that could be a way to be more intentional too. And some patients actually ended up setting up separate appointments specifically to talk about deprescribing. And they found that that was really helpful, because then the focus of the visit could be on deprescribing, and it could be on just taking a step and looking at all of those medications to see if they were still appropriate for that patient. And so that might be something else to consider, because we know when patients come in to visit providers in the clinic, they often have a lot of questions that they want to get answered, or they have competing priorities, and medication deprescribing is maybe not always at the top of the list or something that is a focus of a visit, or that can be a focus of every visit. But it was interesting to see that there were some patients who were really intentional and some providers who scheduled their patients to come back and to have a specific visit that was really focused on that deprescribing. So I thought that was interesting as well. So I do think that there are things that we can do, even if we don't perceive we have a lot of time, to help change our mindset and to change our patient's mindset into how we approach deprescribing or thinking about deprescribing. And that is definitely supported by those authors. So let's spend just a little bit of time going through a clinical scenario. And I tried to use a scenario that was pretty similar to the one that we used in May when we had our echo, so it is not completely unfamiliar to us. But this is a 76-year-old female who presents to your clinic to establish care. She currently lives independently in the community in her home. And as part of her visit today, her medications are reviewed for appropriateness. So we have past medical history here of hypertension, dyslipidemia, type 2 diabetes. Her type 2 diabetes was diagnosed in 2010, but she is resistant to injectable medication use. Generalized anxiety disorder diagnosed approximately a year ago, and insomnia. So here are her vital signs and lab values. And we have a fasting lipid panel from today. We have an A1C from today, which is 7.6%. And then we have vitamin B12 level. She's also taking the following medications. We have hydrochlorothiazide, 25 milligrams, lisinopril, 20 milligrams daily, atorvastatin, 20 milligrams daily, metformin, 1,000 milligrams by mouth BID, glyburide, 1.25 milligrams by mouth daily, pantoprazole, 40 milligrams by mouth daily, escitalopram, 10 milligrams by mouth daily, zolpidem, 5 milligrams by mouth daily at bedtime, Tylenol, 500 milligrams by mouth is needed for pain, vitamin B12, 500 micrograms by mouth daily. So the first question is, what should we do with this patient's PPI? And what does the AGS-Beers criteria say about proton pump inhibitors? So what are some initial thoughts that you have about this patient's PPI? And I'm going to open up the chat so we can see if people are commenting. Do you think this patient should be on a PPI? And perhaps I'll go back here real quick and we'll look at this patient's past medical history. And the lab values and medications that they're on. I don't know that this patient should actually be on a proton pump inhibitor. I don't see in particular any indication for that. If we look at the AGS-Beers criteria, they would tell you that really having a patient on a proton pump inhibitor for more than 8 weeks without a clear indication here would not be something that would be recommended. So there are some scenarios in the AGS-Beers criteria which proton pump inhibitors may be appropriate. So I always think of proton pump inhibitors as a potentially inappropriate medication. Doesn't mean you discontinue all proton pump inhibitors. It means you stop and pause and consider whether the patient is on it for a valid reason that they need to be on it. But proton pump inhibitors have been associated with a lot of adverse effects in older adults too. And so we want to be careful to discontinue proton pump inhibitors when we are able to. And so I'm going to go ahead and go on. If you go to this Canadian Deprescribing Network, they have a great little video on how to deprescribe proton pump inhibitors, and it talks about benefits versus harms. Oh, it looks like it's coming up on here, but I don't know that it'll work for me to play it for you, but there is a really great video that talks about how to deprescribe. And the Canadian Deprescribing Network has an algorithm for proton pump inhibitors. So when I talked about resources that are available, this gives you a flow chart to kind of look at to determine. Now, again, this was published in 2018. AGS Beers criteria have been updated in 2023. It's possible that there are some slight changes, but in general, you get a sense of how you might approach deprescribing a proton pump inhibitor from this website and this recommendation. And so they have a front and back of the page, and the back of the page talks about how to engage patients and caregivers, side effects, how to taper doses, what different definitions are, what different meanings are. So this is a really great resource, I think, that you could look at if you are considering deprescribing proton pump inhibitors for your patients and want a little more guidance on how you might do that best. So the next question is, what should we do with this patient's antihyperglycemics? So if you recall, this patient is on metformin 1,000 milligrams twice daily, and the patient is also on glyburide. And so what does the AGS Beers criteria say about antihyperglycemics? It says quite a few things, actually, about different antihyperglycemics, but one of the things it does talk about is sulfonylureas, and glyburide is a sulfonylurea, and it is a long-acting sulfonylurea. So it is not recommended to use glyburide in older adults, and to try and find an alternative that would be safer for that patient. And so this patient's A1C was 7.6%, and we know that there have been some recent updates to the recommendations for A1C goals when you look at the American Diabetes Association and their diabetes care standards of care guidelines. And so as patients get older, depending upon their frailty and depending upon other factors, you may consider higher A1C goals than shooting for a goal less than 7%. And so that would be a conversation to have with the patient and an individual decision to make as a clinician. But you may decide to add something in exchange for the sulfonylurea in this case, or you may decide that the patient's A1C goal, based on other factors, we don't have all of those here in our case today, you might decide that the A1C that the patient is at is perfectly appropriate for this patient. So that would be a clinician decision, but there is some more information to guide us in making those decisions. And deprescribing.org does have an anti-hyperglycemic deprescribing algorithm as well. And so this again is a flow chart that you can look at, and again, created in August 2018. So we know we've had some updated recommendations, especially if you think about what targets are with life expectancy and targets with frailty and different things that are talked about in the diabetes standards of care guidelines. And there is a page on the back too that again talks about engaging patients and caregivers, tapering advice, gives some information about some of the medications. And keep in mind, again, this is 2018. We have a lot more information about some of these newer agents. So I don't know that I would trust this as being the most up to date for all of the information about when you might prescribe or not prescribe some of the newer agents, but those are talked about in more detail in the American Geriatric Society AGS Beers criteria as well. And then what should we do with this patient's zolpidem? And what does the AGS Beers criteria say about benzodiazepines and Z drugs or sedative hypnotics? And we know that these can be problematic for older adults. And so we generally would not recommend using zolpidem or sedative hypnotics or those benzodiazepine and Z drugs in older adults. And so there are recommendations for deprescribing those as well. And so this is talked about in the AGS Beers criteria. It is also talked about here at the Canadian Deprescribing Network, and they talk about how to deprescribe sleeping pills. And so even with this first page, there's a little video so you can watch that, but they also have a flow chart for how an algorithm for deprescribing and finding out why a patient is taking it, and if there are other recommendations that would be most appropriate. And so, again, I think for the benzodiazepines, it does talk about tapering and how to taper for these medications. And it also has information on the back, like we talked about, for engaging patients and caregivers for tapering doses for behavioral management and cognitive behavioral therapy related to insomnia as well. So this is, again, a great resource that you can use as a starting point for thinking about Deprescribing. And even if part of our conversation today just triggers in your mind as you're looking at patient charts, which medications you should be thinking about a little bit more as potentially appropriate medications to deprescribe, or potentially inappropriate medications that your patients may be on, I think that is helpful as well. And then I have references here at the end. So